Hello and welcome to Diamond Care Inc.'s The Purpose of the UIR and Refusal of ADL Reporting Procedures and Forms. My name is Jenna Silva and I am your narrator for today. We are going to revisit unusual incident reporting, provide a little more step-by-step guidance on how to complete these processes. Also going through, what the difference between an unusual report is and a refusal. So the unusual incident reporting, UIR, is used to document an event involving a resident that is out of the ordinary, that may impact safety or requires a review by management. UI documentation helps to ensure resident safety and timely response, proper communication with administration and healthcare providers, compliance with California Title 22 regulations, and accurate documentation for regulatory review. All staff are responsible for recognizing incidents and reporting them in a timely manner. So what is an unusual incident? So hopefully by now you've watched the first video where we talk about unusual incidences, the timeframes that we got to have them reported. And so a lot of this should be review and information to make you more confident when an unusual incident comes up, on how to respond to it and how to report it, okay? So an unusual incident is an event that causes injury or potential injury to a resident, represents a change in resident's condition, involves a safety risk to a resident or a staff member, requires medical attention or monitoring, and may require notification to a physician, family member, hospice, home health, or the Department of Social Services. What is an unusual incident? So these are going to be your falls, your unwitnessed falls, and that does not mean sliding out of chair or sliding out of the bed. We're talking about falls that we hear and we're not in the room, right? So we do have some residents that they prefer to be on the floor for one reason or another, right? And we've witnessed them, we've seen them, kind of gently lower themselves to the ground. So that is not a fall. A fall is a impact of the resident hitting the ground or hitting an object, okay? Skin tears or injuries. And so when we talk about skin tears or injuries, keep in mind that if it's just like a scratch and there's no more than a quarter cup to a half a cup's worth of blood and it was just basic first aid that was rendered, there's no need to automatically pick up the phone, especially like in the middle of the night or late in the evening, and notifying administration. You're going to fill out your report and we're going to put it in that group chat, okay? Sudden changes in behavior. So this is one that you're going to want to make administration and supervisors aware immediately. Maybe Mrs. Smith is acting very aggressive and that's not her normal baseline behavior, okay? Or more lethargic, they're sleeping more, okay? Things like that. Medication errors. So a medication error is giving a client the wrong medication and or dosage. Choking events, oxygen or breathing concerns, aggressive behavior, not just towards staff, but also towards other residents. Elopement attempts. So this might be looked at as extreme wandering behaviors, okay? Now, this is not something that has to be, reported, right away in the middle of the night. Let's say you found somebody and they were heading towards the front door and they normally don't do that, right? So you're going to document it, you're going to put it in the group chat, and you're going to watch and monitor that resident a little more closely. Now, if they make a second attempt, you're going to notify dispatch. So that way dispatch can maybe pull in a PRN, on-call care provider to come and help provide extra oversight. And we might need to, at that point, if this is a new behavior for that resident, we might need to send them out for an evaluation. We got to remember, we're dealing with clients who have neurocognitive impairments. And so a lot of times when we are doing a new behavior and we're doing it multiple times, we are trying to communicate something. And it very well could be that they're trying to communicate that they're not feeling well, and maybe they're seeking out medical attention without verbalizing it. And then medical emergencies, non-responsive clients that have had seizures, clients that you feel like have something medically going on, very extremely high glucose levels, potential stroke. We will cover those things in another video, signs and symptoms of a stroke, all the things that we know are a little more visual for you guys. I'll make sure we get some videos. But however, if it's a medical emergency, right, and without a doubt that if you don't pick up 911 and call, that this client's life could be in danger, do not call dispatch first. Do not call Jana first. Do not call Amber or a lead care supervisor. Pick up the phone and dial 911 and let them know what the medical emergency is: a seizure, a fall, non-responsiveness, concerns of a stroke, concerns of a heart attack, all those different things, okay? Those are immediately, we're going to have confidence in calling 911. And I know I've mentioned this before in other videos. I am never going to scold you if you felt like that person's life was in danger if you didn't pick up the phone and dial 911. Please pick up the phone, dial 911. Worst case scenario, 911 might show up and say it's not a medical emergency, and they just don't take the client to the hospital. But please don't hesitate to call 911, okay? All right, so we are going to be placing these throughout the community. We'll put them in the UR binder. We'll put them in the MAR books. But this is going to help you guys to be more confident in when to call administration and when it can potentially wait until until it can wait until the next morning and maybe just be a chat message, okay? And so this is considered a decision tree. And so this decision tree is going to help you to know, do I need to call 911 and dispatch administrator and care supervisor? Or is this an event that I can monitor, document, and then report at the end of the shift, okay? And so when an incident occurs, you see the dark blue box, right here up on the top, okay? The dark blue box when incident occurs. And then we have this blue box here in the middle, and this blue box represents a question. And if you answer yes to that question, you'll see all of that is in green, right? And so that lets you know that this is a 911 emergency. If you see the answer is no, it's in red, then this is not a 911 emergency. This is let's document it, monitor it, report it at the end of the shift event. You'll see with the red, we have two different types of documentation. So let's go through this, okay? So light blue box. Did the incident involve immediate danger to the resident? Did it threaten their safety, their well-being, their medical health, okay? So example, fall with head injury, right? Or a fall in general, right? Breathing problems, low oxygenation. Now, side note, if we have a client on hospice and they are experiencing low oxygenation, low heart rate, low breathing, we're not going to call 911. We will call the hospice company. You will then call administration to let us know so we can make sure hospice shows up in a timely manner. Please note, if hospice does not show up within 2 hours of after being called, call dispatch and administrator immediately. Okay. Residents unconscious or they're choking, severe bleed, more than a small bandage or a half a cup worth. Okay. So if it's first aid rendered, we got the bleeding under control, and it's stopped, it's not going to be a yes. But if we can't get that bleeding to stop and we put pressure on it, then it's going to be an emergency situation. Possible stroke, seizure, missing or elopement situation, medication with possible harm. So meaning we gave somebody something like a warfarin, which is a blood thinner, or an anticonvulsant medication. Actually, to be honest, any type of medication error that was not intended for that resident, we are going to call 911. So you see here, it says yes. So if we answered yes to anything in the blue, okay, the light blue, emergency action is required immediately. Do not pick up the phone and call Jenna. Don't pick up the phone and call Gloria or Amber or dispatch. We pick up the phone and call 911, okay? So this helps ensure our residents' safety, and that help gets there in a timely manner. Remember, every minute counts. You're doing the right thing. You're calling 911, okay? Follow 911's instructions. Now, keep in mind, if the client is a no code and we have that pulse form, we're not going to perform CPR, and we will let the 911 operator know that the client is a DNR, a do not resuscitate. Okay. After EMS arrives, okay, so usually 911 dispatch stays on the phone with you until EMS arrives. So after EMS arrives, this is when you're going to call dispatch. You're going to call Jenna, care supervisor. You're going to put it into the group chat, what has happened, okay? And at that point in time, they're going to gather the resident and they're going to whisk them off to the hospital, okay? And so before you sit down and do your UIR report, do a quick check on all of the residents, okay? Make sure everybody else is doing okay, because sometimes these emergency events can really cause some mental distress for our clients, and they could potentially try to wander away. Okay, so we're going to do a quick check on everybody, make sure they're okay, they don't need anything, and they're all safe and they're sound. Okay, and we're going to sit down and we're going to complete this UIR report, and we'll go over that here in the next couple slides. So remember, once again, if the client is on hospice services, you're going to, instead of picking up the phone and dialing 911 right away, you're going to pick up the phone and you're going to call dispatch, okay? And then you're going to call 911 if you're instructed to do so, okay? Because there are some reasons why, if somebody's on hospice, we still might call 911. So for example, a fall with a head injury, a fall with a potential broken bone, okay? So just because they're on hospice doesn't mean we withhold emergency treatment. But however, a lot of the most common emergency treatments are breathing difficulties, potential heart attack, stroke, things like that, and that could be part of their disease process. So you're going to pick up the phone, call dispatch, call Jenna, call care supervisor, whoever is in charge, okay, call administrator, and you're going to let them know the situation, and they're going to probably call hospice or direct you to call hospice, and then hospice will let you know to call 911, or will let you know to call 911. Okay, so off to the right side of the screen, we said no. None of that happened. Nothing that was emergent or life-threatening took place, okay? So did the incident cause injury or a change of condition or a safety concern? So some examples of that are minor scare tears that just required basic first aid, sliding out of their chair or their bed on their own free will. You witness them doing it, right? And maybe this is the first time of them doing it, right? Behavioral incidences, maybe they're yelling, they're screaming, they're cursing, right? Maybe they're fighting with other residents, or they're trying to pick a fight with you, okay? Near fall and medication refusal. So if you answered yes to those questions there, then we are going to still do the unusual incident report form, okay? And you're going to make sure that you do this form before your end of your shift, and we'll go over the form here shortly. But if you answer no, and it's more on the lines of they refuse to eat that meal, okay? They refused a medication one time. They refused a bath. They refused to brush their teeth. They refused to be repositioned or gotten out of bed. Those things are documentation worthy, but they are not in the middle of the night or late shift picking up the phone and asking, what do I do, right? So those incidences are both, reportable, two different forms, okay? But the second one is a refusal. And so you'll see in your MAR book for each resident, refusal of care, okay? And so it's really simple. You fill it out. And then if they refuse care more than 3 days in a row, then we're going to let somebody know. Maybe for the last 2 days, they didn't feel good. On this third day, they're going to take that shower, okay? But if they go 3 days in a row refusing that shower, then we're going to call somebody, especially if it's a Saturday or Sunday, okay? If you have any questions on when to call or not to call, please, give me a call, 916-865-6233. Hopefully you have my phone numbers by now. Also, you can find me in the office, pull me aside. Don't ever be afraid to ask me a question, okay? I know we have a lot of, changes, occurring. There are things that we used to do and we don't do. And so don't ever feel like you're going to be in trouble. It's all a learning experience. And I will be honest, things that we can do right now, the state might change the rules and we might not be able to do them in the future. Or we might be granted permission to start doing some of the things that we used to do, okay? So it's all about state approval. What is our staffing like? Do we have an RN or an LVN available to us 24 hours, 7 days a week, where we're doing more of the things that we used to do, okay? But for right now, if you're for sure what we can or cannot do, please just reach out, and just bear in mind, 6 months to a year from now, some of these things may change. And if they change, we'll provide new training and new updates and all of that, okay? As you know, anything with the government is subject to change at any point in time, and it can change with no notice too. So just be patient with the process. Don't be scared to answer questions. I love to teach you guys and educate you guys. Maybe someday you guys will, go on and, become LVNs or RNs, or go get your, healthcare administrative degrees and become healthcare administrators. And everything that you're learning here at Diamond Care is going to give you a great foundation to be successful elsewhere. Okay? All right. So on to our next slide here. Okay. Okay, so hopefully everything goes smoothly. With the video, I did have a little slide mishap, but we are now on emergencies and immediate action required. So remember, staff are responsible for calling 911 if needed. Do call me first, okay? Call 911 first. Then notify dispatch, notify me, notify care supervisor in charge, Amber, CR, whoever it might be. We are going to do our URI documentation, and we're not going to wait until the end of the shift. But however, if we're not able to get to it within the reasonable amount of time that we should be getting to our reporting documentation, we're just going to go ahead and make sure it's done before we go home. I repeat, do not go home without it being done. Sometimes things can get very chaotic and crazy and hectic, and if you have to stay over to complete a report, you're just going to notify us and let us know, okay? So that we are aware that you stayed over, your overtime is approved, and the reason why you're staying over, okay? So we're going to kind of recap again situations that must be reported immediately, okay? After 911, right? We're going to notify dispatch. We're going to notify the administrator. We're going to notify the care supervisor, and any kind of fall, especially a witness, sudden change in mental status, oxygenation concerns, respiratory concerns. Injuries require beyond basic first aid, medication behaviors, behavioral incidents revolving resident safety, up and over the fence, and they've eloped and we cannot find them. And then another one that is reportable right away, but we don't call 911 on, would be family complaints involving care concerns. I know sometimes this can be an awkward topic, especially, when a family comes in and says, Sue Jennings is not getting her teeth brushed, right? Or I know my mom's been in the same clothes for the last 3 days, right? So it can feel almost like tattletelling on our coworkers, but sometimes there's reasons behind why some of these things aren't getting done, right? Maybe the resident's refusing, right? And we have to respect their right to refuse, right? And so if there are any family complaints or concerns, you are going to report that to us right away. So incidents that can be documented before the end of the shift, okay? Some of these events are not emergencies, but they still require documentation, okay? So they're not 911 reportable. So once again, we're just kind of do a little bit of a recap here. These can be documented before the end of the shift. So minor skin tears that were treated with basic first aid, right? Resident refusal of medication, minor behavioral incidences, residents refusing care, minor equipment malfunctions, such as the toilet running, right? The kitchen sink has a drip, okay? Resident complaint or concern, and a non-injury fall or near fall. So once again, a client who maybe was never a floor sitter, and now all of a sudden they've decided they like to sit on the floor. Okay, so we still want to document that, but it's not picking up the phone in the middle of the night type of emergency. Okay, use your guys' best judgment. So what I want to kind of emphasize here is if it's, after 9 p.m. and before 7 a.m., right? So that kind of covers the PM shift and the knock shift. Ask yourself, would you want to be woken up because somebody has a new bruise on the top of their hand and you don't know what to do about it in the middle of the night? You probably won't. Are you going to want to know about it being a care supervisor? Absolutely, right? But it's not a let's pick up the phone event in the middle of the night. It is, however, let's document it and monitor it and report it at the end of the shift type of event. And so what I mean by end of the shift, so if we are the 3 to 11 shift and we notice something, we're going to report that to our replacements. We're going to make sure it's documented, and we're going to throw it into the 100 or 200 chats as a FYI, for your information. SDS has minor bruise on top of the left hand, documented, monitored throughout the night. Okay, we're not going to pick up the phone and call dispatch and ask them what to do. On the other hand, client is complaining that they have unusual pain, and it's not like an acute pain. Like I'm talking about like a headache. Maybe their wrist hurt, their feet hurt, they're achy, they have arthritis, right? You're not going to pick up the phone and say, Jenna, Gloria, Amber, what do I do? Because our first question to you is going to be, did you review the medication administration record? Did you check if there is a PRN medication? And if you didn't do that, that's what we're going to tell you to do. So put our thinking caps on and say, my resident just reported pain. So I'm going to go check to see if I can give them something. We are in the process of making sure everybody gets a over-the-counter order form of what we are allowed to give them and not allowed to give them. Okay, and so hopefully this will help relieve minor aches and pains, throughout the night. So we're still going to document that in our MAR, and we're going to maybe throw it into a group chat. FYI, DSD had a minor headache, provided aminocentephine, also known as Tylenol, was on their PRN medications, and that's it, okay? We're not going to pick up the phone and ask what to do. However, if we don't have a PRN medication and the client says that they cannot go without some type of pain relief, that is going to be, let's pick up the phone and call dispatch and see what to do. We might send them out if they feel like they can't wait until morning for us to call their primary care physician to get them something for pain. However, if they are on hospice, we're going to call their hospice provider right away. All of the hospice patients should have something for pain, but if for some reason it is not, we're going to call hospice. Once again, you got any questions about this, please don't hesitate to come and ask us, okay? Okay, so now we're getting to the nitty-gritty of incident reporting, okay? So by now, y'all should be very familiar with this form. Realize this form is potentially adjustable. So meaning if there's a section or a common thing that is not listed on here that you guys feel like I overlooked, please let me know. I'm human and I don't think of everything, right? And so this form is open to being edited and molded towards what works best for us here at Diamond Care. So information that is required on the DCI UIR form. So staff must complete all sections of the report, okay? And so you're only going to check the boxes if they pertain, but you're going to review each section to make sure that you get as much information on here. So resident's name. We need first and last name. I know we're used to doing initials, but here's the thing. If these forms are somehow out of their binder, and let's say it's 2 or 3 years down the road and things get kind of disshuffled, we might have multiple JKSs, right? We might have a Jacqueline Kennedy Smith, right? We might have a Genevieve Christoph Silverado, right? And so we might not know which JKS that form belongs to. So really make sure we put the first and last name, okay? That's for state purposes. So date and time and of incident, location of incident, description of what happened, keep it to the facts, okay? Injury observed, if any, scrape, bruise, whatever might have you. Actions that were taken by you guys. Did you call 911? Did you put it in the group chat? Etc. Who was notified? Follow-up instructions. Maybe there's something that the next shift needs to do with this, okay? And this is part of throwing it into the chat and also reporting it to the relief person who relieves you at the end of your shift. And then staff signature. And as always, document the facts only, not your opinions. In my opinion, if he would quit ordering fast food, his sugar level wouldn't be 500, right? Facts only. Resident keeps ordering takeout and sweets that are not compliant with his diabetic orders. That's the fact, okay? Okay, this page is the first page of the UIR, also known as Unusual Incident Reporting Form. And I made it as simple as I possibly could for you guys, where we're going to check box it, okay? So you're going to check all that apply after we fill out the name, all that top part information, okay? Was it a fall? Was it an elopement? Was it a medication incident? Was it a behavioral incident? Was it a change of mental condition? Is it a skin issue? What actions did we take? Transfer the hospital, call 911, call the administrator, evaluate and just monitor. Did we call the sheriff's department? Did we just do a over the phone report? Did we call home health? Did we call hospice? Who did we notify? Okay. And then we're going to cover where did this incident take place, in their room, in the bathroom, in the dining room, in the hallway, on the outside patio, off-site appointment, or other. Okay. And then we have our immediate action. So, you know, assessed resident, took vital signs, performed first aid, notified administrator, called 911. Some of this is, you know, repetitive, but the idea behind this is what was our very first things that we did. Because we might have had somebody who just didn't seem right and we were monitoring them, and then all of a sudden they become a 911 call. Okay. If you got questions, ask. So here is a area that you can write a synopsis of what happened, but bear in mind, if you are going to write a description of what happened, keep it to facts only, no personal opinions, okay? And then injury information, if there was no injury visible, minor injury, major injury, pain reported, body area of injury, okay? And then you're going to go ahead and sign it and date it on the very last page. And then administrative review, myself, Gloria, care supervisor, somebody is going to finish out that last section right there. So what do I do? Where do I put this information when it's done? So hopefully by now y'all have seen the blue binder, unusual incident reporting binder. There's 31 tabs. Why 31 tabs? Well, 31 tabs represents the days of the week. And so if the event happened on the 10th of the month, so like August 10th, we're going to put it underneath the 10th tab, okay? And this way, at the end of the month, we're going to review all of the incident reports, and, you know, daily when administrative staff comes in, we're going to check the binder for anything that needs to be reported to the state right away. And it also gives us data. It gives us data so we can make corrections, maybe provide additional training, maybe we need to get additional staff, maybe we need additional equipment, right? So all of this information helps us with those determinations. And so this binder should be in that little corner part of the office and 100 in the administrative area. If you're not for sure where it's at, just ask and someone will be happy to point you to the binder. So let's recap this form. What happened, where it occurred, what time, what resident was doing, what this staff observed, and what actions were taken, okay, along with resident name, date, all that fun stuff. So if we decide to use the blank space to fill in what happened, here's the incorrect way to fill it out. Resident fell because he is weak. We are not clinicians, we don't know if the resident was weak. We don't know if he had a stroke. We don't know if maybe his hip broke. And believe it or not, seniors, their hips can just snap if they don't have great calcium and vitamin D and things like that. That sometimes happens. A bone can snap and it can cause a fall. So we don't know why he fell. So saying resident fell because he is weak, we can't write that. However, we can say at approximately 2:10 p.m., resident was observed sitting on the floor next to his bed. Resident stated he attempted to stand without assistance. Staff assisted resident back to bed and completed safety assessment. So if the resident's not reporting any pain, we can get him back up on bed. But however, if the resident fell and we knew he fell or we heard a fall, we must send them out for a proper medical evaluation at the hospital. Once again, I sound like a broken record, but we're very special here at Diamond Care with the clients that we take care of, and we take care of people with neurological cognitive impairments. And so that's, dementia, Alzheimer's, Parkinson's disease, Lewy bodies, frontal lobe dementia, bipolar, schizophrenia, all kinds of different neurological impairments. And they might not recognize pain, that they've hurt themselves. And so we don't have x-rays, we don't have CAT scans, we don't have MRIs, and so we must send them out via 911. So recap on important documentation rules. Don't guess what happened. Only report on what you can see and what was reported to you maybe by the resident or a witness. Do not assign blame. We cannot say it's one person's fault versus another. And unless there's a reason to do like a full investigation, we're not going to assign blame. It's, we don't know. Unless you witnessed it, we don't know. Do not include opinions. Well, I feel like if Jenna wasn't on her phone, she would have been watching her residents better, and they wouldn't have fell. So we're assigning blame, okay? And we're giving our opinion on why they fell. Do not alter the document later. If you need to go back and add or change something, get a new one and write on there updated information. And write on there why we are updating it. Maybe, after we sent, Sally, Jones, Parkinson's out to the hospital, maybe Miss Parkins' roommate said that right before she fell, she was acting weird and not like herself, okay? And so that's kind of important information, right? And so you're going to want to change it or update it, but you're just going to get another new form, write all the information in, write update. After Miss Parkins went to hospital, roommate reported she wasn't acting like herself, okay? And then always remember clear, objective, factual information, okay? Okay. So we're gonna, move into other things that are absolutely reportable, but they're not unusual, incidental reportable, okay? And so this primarily is going to pertain to the activities of daily living, ADLs, okay? And, moving forward, anytime we have a resident who is refusing an ADL 3 days in a row, and honestly, it can be 3 different ADLs. Okay, one day they're refusing to eat. The next day they are refusing to get out of bed. And then the third day they're refusing to shower. Okay, so 3 days in a row they have refused an ADL. So that is going to be something that we're going to pick up the phone and we're going to report it in. But what we're going to do, when it happens the first time is we're going to document it, okay? And so once again, as mentioned before, you'll see these refusal of ADL tracking in the MAR books that you guys can go in and write it in. If they, refuse one day and the next day they participate and refuse again the next day, and we see a pattern, then, we might need to figure out how to change our approach with the client. But once again, we only have to really worry about reporting it when we hit the 3 consecutive days, okay? But make sure it is documented. So some examples of reportable refusals of ADL's activities of daily living are hygiene refusals. So resident refuses to shower or bathe or bed bath, right? They refuse to brush their hair, they refuse to shave, they refuse to have oral care, denture care. Sometimes our clients might not want their dentures removed. And we got to be really good stewards of care and do what we can to get them to take those dentures out, at least at minimum every 24 hours, to scrub them really good and get them clean, okay? Because they, older adults with dentures right now, majority of them are going to have adhesive that is applied to the denture, and that adhesive can actually ruin their roof of their mouth and their gums if it's not cleaned and reapplied appropriately, okay? You might start seeing some seniors with the snap-on dentures, and so therefore they have metal posts in their mouth, and those metal posts make the teeth more stable. They keep the bone structure in the face more healthy, and they don't require adhesive glue. However, they still require to be removed at least 24 hours a day and brushed and cleaned really well. And if we get somebody in with these newer pop in and pop out dentures with the locking device, ask how to do that. There are special ways that we pull those in and out of a resident's mouth, okay? And if a resident declines shower assistance 3 days in a row, yes, you're going to report. If they refuse oral care 3 days in a row, or they refuse shower 1 day, groom, and then oral, you're going to report, okay? And the reason being is there might be something going on there that we need to assess. So some other examples, dressing assistants. Maybe they're refusing to put on clean clothing. Maybe they are refusing assistance due to mobility limitations. They might not understand or realize that they need assistance to keep them from falling, or maybe they've had an injury to a hip or a shoulder and they think they can do it on their own. So especially in those instances, we need to make sure everybody's aware, and we need to, help educate them as best as we can to allow assistance. And then, changing soiled clothing. So sometimes our residents, they get that favorite piece of clothing, especially when they have advanced stages of, neurological inefficiencies. And so, no, this is not a UIR report event, but it is a reportable event on the refusal of ADLs. So, example, resident repeatedly refuses help to change clothing despite encouragement. You're going to put that on the refusal form and you're going to track it. And then after 3 days of this happening, you're going to report to your supervisor verbally. So other examples that are not UIR reportable but ADL reportable are mobility issues. Resident son refuses assistance. I'm sorry, not son. Don't ask me why I said son. Resident refuses assistance to get out of bed. refuses assistance with transferring, and maybe we know that they're too weak to transfer. A really big one, refusing to use an assisted device such as a cane or a walker, right? They might not understand the importance of it, and they don't have a habit of getting up and using it, right? So we're going to encourage them and redirect them to use that safety device. So resident refuses assistance with morning transfer from bed to chair multiple days in a row. We need to know, okay? So you're going to let us know that they're refusing to get out of bed, and they probably are going to need some kind of assessment, okay? So more examples, toileting assistance. Maybe they're refusing assistance to go to the bathroom, and they're having more incontinence issues. And so if this goes on for more than a couple of days in a row, they might have something medically going on with them. So we absolutely need to know. Changing of incontinence briefs. A lot of times the residents want to maintain dignity and do these themselves, but they might not clean themselves up very well, or put the dirty brief in the acceptable container, or they might try to flush it, right? So you need to let us know if they continue to refuse incontinence brief assistance. Also, if they're refusing you to clean their private areas and they are incontinent, we don't want to have a bed sore or a bladder infection, start up. Resident refuses change despite staff encouragement. So you've done everything you can and they're still refusing. This is a verbal pick up the phone, send it in the text, thing to let us know. Nutrition assistance. If we have a resident that skips a meal and they are diabetic, we need to know right away. Reason being is diabetics really need to have consistent meals, because when they don't have consistent meals, then they're not getting their insulin on a consistent time frame, and this can cause potential issues. And so we need to make sure that we are notified right away on our diabetics who are refusing meals. However, if somebody who's a non-diabetic refuses one meal, a day, 3 days in a row, we need to know. If they refuse to drink, if they refuse to come out to eat meals, these are all things that we need to know, but it's not a UI reporting, it's an ADL reporting. If they are on hospice, keep in mind, hospice residents, as they start to decline, will not eat and drink. We still are going to report it on a reporting form, but our approach with them are going to be a little different. Another reportable ADL event is going to be for our bedbound patients, our patients who are mobility dependent. So these are going to be our complete, maybe paraplegics, very deconditioned residents, so turning in bed. If they're not on hospice and they're refusing to turn in bed every 2 hours or repositioned in their chairs every 2 hours, we need to know if this is happening. Assistance in preventing pressure ulcers, so if they're refusing gel pads or whatever the case might be, okay? The bed-bound resident refuses turning assistance during the day. So this is a really big one, because at night we're probably doing it maybe every 3 hours versus every 2 hours. So if they are awake and it's wake time hours, we need to be repositioning them every 2 hours. And going from a bed to a chair counts as repositioning, okay? And so what I would like to see is all of our bed-bound patients, if they're not on hospice, let's get them up into the chairs for each meal, right? And then after the meals, they can return back to bed. This is a great, better way to eat, less likelihood of choking, and it helps with repositioning and prevention of bed sores. When refusal becomes reportable, so administration should be notified if Refusals become consecutive 3 days in a row. Staff notices significant weight loss. So let's say in the course of 2 or 3 days, you're like, I think there's a good poundage of weight loss happening. You're going to report it. Skin breakdown, reportable immediately, or any health decline. Okay, so any health decline, you're going to report immediately. And then refusals on that may impact the safety or hygiene. So they're sitting in the same brief for multiple hours and they're refusing to be changed. We need to know right away, okay? We can't let them go days without having a brief change. Now, them trying to change it on their own, you know, that's something that, you know, happens, but refusing to completely have it changed, we need it to be reported immediately, okay? And this can, you know, if it's in the middle of the night, it can be reported on the end of the shift. And then, however, you know, when shift change comes, really 2 caregivers should go in there and have that brief changed. Okay, so we are at the end of this presentation. There will be a little bit of a post-test review for you guys to do. This really should have been very much a reminder, refresher type of video for you, maybe clear up some questions about the form and when it's appropriate to make a call in the middle of the night and when it's not appropriate. I want you guys all to have confidence in your ability to be a care provider. We don't hire everybody who comes through Diamond Care through the externship programs. We only hire the ones that we clearly feel are going to make an impactful difference and are able to put our residents' safety above all else. Okay, and so go back to your training. Okay, go back to the basics. If they report pain, did you check the MAR? If you think what's happening is a life-threatening event, call 911. Okay. You guys have got this. We know you got it. So remember, you can go back, review this video. Reportable things on the decision tree that need to be reported right away or 911 called right away are all in that green, right? And the things that are in red, such as refusals, you saw maybe a bruise, things like that, we're going to document, monitor, and then throw it into a group chat as for your information. But as always, if you have questions, you have concerns, maybe I didn't address something, or maybe I didn't go into enough detail, please let me know, let Amber know, let Gloria know, let Zach know. We are here to help you guys grow. So I hope you guys have a great rest of your shift or day, whatever the case might be. And we're looking forward to the next videos.